I have now used some of that negative feedback, the noise, to move me or push me out of my comfort zone into an area that I would not have gone if I had not gotten that push. So sometimes, yes, you have to shut out some of the really dark noise. Something that I hope to see in the future, there's not a specified code for, bacterial reduction or even decontamination. So what I see most offices or facilities doing is billing out kind of a D4999 as an unspecified periodontal code. If you feel stagnant in your career or you're questioning, why did I do this? Why did I get in here? I'm just clocking in, clocking out. I'm not getting fulfillment in my career. Seek out more information. Go to classes, seek out information, challenge yourself, go out of your comfort zone and see what's out there.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 347. I'm your host, Andrew Johnston, and thank you so much for listening today. It's going to be a fun show. We have Alyssa Delgado as our featured speaker today, someone I've known for several years, and she's going to be talking about local anesthesia, a little bit about diode lasers, and we're also joined, because we did record this at RDH Under One Roof, we were lucky enough to have Erika Flateau again as our guest co-host. I don't think that the background noise is going to be too annoying for you all, but I do apologize. I know that that's going to be coming through on several of these episodes, but it was just a really great encounter with Alyssa, and it was just, we had to get her on the show. So hopefully you guys will bear with any of those little imperfections. And then don't forget that next week we will be starting the first of 4 episodes in a row partnering with Dexus Imaging for their Dexus Days. We will only be doing 4, but they have plenty of other courses that you can choose from. So be sure to check out their website to get that full lineup of the courses that they're going to be offering. And they do have some that are during the day and some that are in the evening. So we had a really good time this past weekend in Kansas City at the annual meeting for credits. And I think it's interesting because depending on where you went to school, in certain parts of the country, there's a good chance that you have no idea who or what credits is. And it's an abbreviation. It stands for Central Regional Dental Testing Service, so CRDTS credits. So if you went to school on the West Coast, probably a good chance that you took a REB exam. Until recently, credits wasn't giving very many exams, at least for hygiene, out on the West Coast because they were a central regional dental test. So the same might be true if you were on the East Coast. You might know NERB, or Northeast Regional Board, or the South could be CERTA, Southern Regional, South Region Testing Agency, or something like that. And there's any other number of ones that could have existed because at one time, there were truly regional testing agencies, but as things have changed over time, so has the dental testing landscape. There are so many states that accept all testing agency exams, and then there are a few, like Florida, to name one, who will only accept the 8X exam. Well, many of you know that I have been an examiner for credits for several years, and I've also served on the steering committee, and I'm not really sure if I mentioned it though, but last year I was elected to be the secretary-treasurer for credits. And well, this year, the nominating committee put forward my name and I was elected to vice president. So I'm really happy about this. It's a great group of people that I get to work with. They are so hardworking. They just want the best test for the candidates to take. They want something that's going to be fair, but they also understand that they're working at the discretion of the dental boards from each state, and they want those exams to make sure that we're protecting the public. And so I've seen behind the scenes of how these tests are created, and it's absolutely amazing. I love the people over at Credits, so I'm really excited for this opportunity. Also, a special shout out. First of all, we have lots of friends that are in this hygiene industry that also were attending. So I'm happy that they were there. It was never a dull moment. But a special shout out to the speakers. So we had 4 speakers, and they really delivered great content, great courses this past weekend. Dr. Gupta, Dr. Emily Bogie, Amanda Hill, and Amber Levados. Thank you so much. It wouldn't have been the same without you. If anyone has any questions about credits specifically, you guys can go ahead and send me an email, andrew@atailof2hygienist.com. I think one thing that you are probably wondering about is mostly about that whole portability thing, right? We talked about that a lot a few episodes back, but the exam for hygiene for credits is accepted in most states. It's absolutely ridiculous, the misunderstanding that's out there. So if you guys go to credits.org, crdts.org, if you scroll all the way down to the very bottom, you'll see they call it a portability chart, but it's a map of every single state that accepts the exam. So if you took a credits exam, it'll be accepted in all of those states. So when we're having these conversations about portability of licensure, which is a whole different thing, that isn't really about the exam that you took. So anyway, I think that's all for me and my rambling for this week. I hope you enjoy this episode with Alyssa Delgado.
A tale of two hygienists.
Hey friends, quick pause in the show to remind you about the CE offered for several of our episodes. All you have to do is click into the show notes and follow the link to the CE Zoom website. Answer a few of those questions about the episode correctly and you'll be rewarded the appropriate amount of CEUs. This wouldn't be possible without a partnership with our friends at Tempstars. Tempstars is more than just a temp and a placement service. They are clinician-led and education-focused and strive to perfectly match individuals and dental offices. Learn more about Tempstars.com or go back and listen to some of their tip episodes. They are absolutely worth the listen. And now, back to the show. All right, everyone, welcome in. We have a special guest today. Alyssa and I have actually known each other for several years. It's been fun to watch kind of your journey as we both kind of are growing in this profession. And I think, when we first met, I still know almost nothing about you, so I'm not going to pretend like we're BFFs. But when we first met, I feel like we were both like ready to start.
Yes.
We're going to start something. Did you have a direction of what that was going to be?
I had an idea, but I don't think I knew exactly the trajectory that my career or my life would take. And I certainly didn't imagine when I met you fresh out of dental hygiene school in New Mexico that I would then 5 years later be living in Minnesota. So I didn't know exactly what that looked like, but I knew you and I had the same kind of hunger that we wanted more. Mm-hmm. We sought something, we had that passion. So I definitely it's cool to see you grow in your career too, because it's just up and onward for both of us.
Isn't that crazy? And I think, what would you attribute that to? Why do you think that you've been as successful as you've been?
I think for me, my success has really come through personal connections with different hygienists just like yourself, and a variety of other hygienists that I've met through both the professional association and at national conferences. Mm-hmm. Those connections and hearing other inspiring stories has really propelled me into finding my niche and kind of what makes me unique and what I've found success in. But I really attribute it to the network of people and the kind of warriors behind me and the people that have led the way before me.
Isn't that incredible?
It is.
Let me ask you this. But we have a whole bunch of things we need to talk about today, but I'm just so fascinated by you. Like, how do you, and maybe this isn't happening to you, but I feel like we've all gone through it. How do you kind of block out the noise, right? Because when you're finding your niche, or niche or whatever the word is, you stumble into things that you are trying to be passionate about, but then it doesn't work, right?
Yes.
Then you have to pivot, right?
Yes.
And then you have people kind of maybe in the periphery that are maybe not as supportive. Like, how do you block that out?
Yeah. What I've actually learned is not necessarily to block it out completely, but to actually use some of that feedback to kind of navigate and move me into the correct position. For example, when I was I'm in my educational career at my college, and I'm extremely passionate about lasers and diode lasers, and I went to the college and I'm very passionate, and I said, we need to educate our students on diode lasers. They need to be certified when they're coming out of school. And they immediately said, absolutely not. That is not something we're interested in. We do not want any part of this. And that propelled me to create my own business and do it myself on my own. And so I have now used some of that negative feedback, the noise, to move me or push me out of my comfort zone into an area that I would not have gone if I had not gotten that push. Yeah. So sometimes, yes, you have to shut out some of the really dark noise. And I think the biggest noise to be completely vulnerable is from my own self. I think I'm a huge
imposter syndrome.
I'm a huge critic of myself.
Yeah.
And even speaking today, I was up at 12:30 a.m. trying to tweak my PowerPoint presentation because I felt like it needed something different or added something. And so I think for me, the noise is in myself, and it's something that it's a daily thing to help, keep telling myself, like, I do have something to say. I am okay here,
Yeah. We're going to come back to the diode thing in just a little bit. I can feel the passion emanating from you from this side of the table. But it's interesting about starting your own business. I want to talk about that for just a quick second. Maybe share with us, maybe something that was unexpected. Maybe it was a success or maybe it was a failure. Like, what was the best part about starting your own business or the hardest part or something that just you didn't expect?
Yeah. I would say for me, actually, the nitty-gritty of starting a business actually was way easier than I anticipated. Filing for an LLC and picking a name, and all of that was fun for me, and it was relatively seamless, super smooth. So that surprised me. I thought it was going to be this big whole document and all of these things. So that was actually relatively easy. But what's been challenging for me is balancing kind of all of my balls in the air of being a full-time educator, working part-time clinically, and now I'm a one-woman show trying to, educate on the side and do this. And I have interest, but then I really have to be very mindful of when I can say yes and when I have to say no to certain opportunities.
Yeah. I feel that. I feel that so much.
The no's are really hard because I'm a yes person.
You want to please?
I am. I'm like, yes, this sounds like a great opportunity. But the no's are there to allow you to do things for your yeses.
So everyone also, by the way, that big awe was also for what Alyssa just said, but also for that dog that's behind us.
Yes,
that is like the cutest little pup that ever did exist.
He's been hanging out all day.
Huh?
He's been hanging out all day. Gibbs.
Oh, sorry. Thank you, producer. We got to give a shout out to Gibbs. Follow him on Instagram. He's a Siberian husky.
Yeah.
Okay, so I promise we're going to get back to diode. So maybe give us your top maybe interesting facts or top tips or top anything you want about diodes, because I don't think that this is something that the everyday hygienist necessarily is exposed to. Right. So what can we tell us?
Absolutely. One of the things that I kind of see the light bulb moment happen, or things that maybe catch people off guard, because I know when I went to school it was, there's not enough research. There's not enough research on diode lasers. Maybe you'll see things anecdotally or in a clinical basis, but ultimately no research on it. And what I've found in my own research going through diode lasers is when you look at SRP alone with an SRP with a diode laser, depending on what you're looking at, which the diode laser is there for reducing bacteria and working on that cell wall and killing that bacteria kind of on a cellular level. When you're comparing bacteria levels to SRP alone versus an SRP with a diode laser, the diode laser wins every time, even 3 months after the therapy, because that's what you're looking at. If you're looking at bleeding on probing to bleeding on probing, there may not be a statistical significance, right, between the two. Or if you're looking at even probing depths, really strong hygienists that have very high levels of skill in their SRP alone can reduce pocket depths. That's what we already know, and that's something that will never go away. That is absolutely the number one therapy. But when you're dealing with a bacterial infection, that's what the diode laser really stands and shines in our kind of adjunctive services that we can provide to that patient, rather than just saying, well, the research isn't there. The research is there if you're looking at the right thing. So if you're looking at bacterial levels, that's what the diode laser really shows as being a significant impact in patient outcomes.
Holy crap. Your number one was like off the chart.
And
I don't know how
is
you're
it
going to follow that up.
bacterial eradication of the, our scaling root plane is going to disrupt bacteria, but the actual killing of bacteria is exciting. Does it do any sort of biostimulation that can help in the healing process after SRP?
Absolutely. And I like to say it's kind of throwing a stone or a pebble in water. There's a ripple effect, and we're talking about thermal energy. So this is heat, and that thermal energy has ripple effects. So the further away from the site of origin, the less, energy is there. What happens in those ripple effects or in those waves is biostimulation. So in lower levels, that's really where you can get, advanced healing and fibroblast interaction, osteoblastic interaction. So it really not only provides, inside the pocket, it's helping, but it provides this ripple effect outward. So that's really where I see it being of a great benefit for patients.
Is it like a biological Band-Aid when you're done? Does it cauterize or clot or anything?
Oh, good question. Yeah, so
That's what she's on, by the way.
I'm
going to sit back and relax. You guys got this show.
I love this. So in certain states, it's also very important to check your scope of practice, but in certain states that dental hygienists are allowed to do curettage, the diode laser can act as that curettage, and so it can go in there and actually remove that necrotic tissue from within the cell or within the pocket lining. So in a way it's cauterizing, but it's more so kind of removing that necrotic tissue, but it's also sealing off the lymphatic system there. So it's stimulating, but it's also kind of sealing everything off. So it does kind of provide that, new growth of the tissue to heal.
And lastly,
Keep
any
going.
bone regeneration ever, even a tiny little bit?
Okay, so I was in school, we never grow bone back.
Right.
Gone forever and ever. Goodbye.
Yep.
And I had a patient that had an implant and had it dislodged, and so there was a lot of infection around it and zero calculus. I mean, there was no factors, no cement, no nothing. And so I knew immediately this is bacterial and there's something deeper that's going on here. And so rather than playing around with my plastic scalers that we all love, I really focused in on my laser. And I'm like, we're going to treat this bacteria around here. And the following year, I did a kind of post-op PA to follow up on it. And there was 2 millimeters of bone.
I love it.
So in a way, like, we're seeing a lot more of this, and I'll cover kind of that photobiomodulation, but I really think that sort of laser technology of using photobiomodulation or actually stimulating osteoblastic or fibroblastic activity should be the standard of care when we're talking about bacterial infections.
Fantastic.
But is it fair to say that is the expectation that it will for sure regenerate, or is it like, hey, it could be this is a potential of a side effect
at this point, what I'm seeing in the research is it's still fairly new. It's very promising research as far as that kind of osteoblastic activity, but I think it's still fresh in the research to get kind of the full, this is 100% guarantee.
Yeah.
I was just going to say, when you see an implant failing and you start seeing threads exposed, you're like, well, this is a goner. It's just going to keep progressing.
Yes.
So that gives some hope to maybe regenerating a little bit of bone or saving that implant.
Yeah, absolutely. And the implant went from having mobility to being rock solid. So it was a really good patient experience for me to have right off the bat, because then I really got to see the true power of what the laser can do and how it can impact our patients.
You're a fascinating individual.
Well, thank you.
Oh my God. I
agree.
I'm just like a big nerd. Big nerd.
Well, we're
So-
battling over
Samesies.
getting to ask you about this because it's so exciting.
No, this is your show. Let's do this, Erika. No, you've been a great
zip.
co-host. No, you have. So what else do we need to know? Like, what are some other things that I guess wouldn't be considered common knowledge?
Common knowledge. So with the diode laser, It's interesting because there's a lot of new research that's come about kind of in the post-pandemic world where we're really looking way harder at pre-procedural activities, right? So we want pre-procedural rinse. Okay, well, what kind of pre-procedural rinse? What are we exactly trying to do prior to aerosolizing this, oral saliva and bacteria? And one thing that I've seen the laser do a remarkable job at doing is that laser bacterial reduction, even in a pre-procedural format. So going in there, it does a really fantastic job of reducing that microbial count, not necessarily replacing, obviously, a pre-procedural rinse, but it, again, is something, if I'm going into a highly diseased pocket and I'm aerosolizing this tissue and this saliva and fluid, I really feel way more comfortable and confident when I know that I've gone in there with that laser and done my first swipe of laser bacterial reduction. Now I'm going in there and actually disrupting with the scaling and replanning procedure. And then I can go back in for that actual decontamination where we're removing that necrotic tissue.
And how much time would you take for each pocket or each site?
So it depends on the procedure you're doing. For laser bacterial reduction, kind of in that pre-procedural format, you can do the whole mouth. It takes about as much time or a little bit less than probing. So, you could do it in 1 to 2 minutes for the whole mouth. You're just spending a few seconds on each tooth. When you're doing something like decontamination, where you're going pocket by pocket and really focusing on the necrotic tissue, it's generally recommended to do about 5 to 10 seconds per surface. So per surface of the tooth. So it adds a little bit of time, but honestly, in the grand scheme of a scaling and replanning appointment or a therapy appointment, it doesn't make any, it's not like, oh my gosh, I have a whole nother thing to add to my list, Which
is the common thing. We talked about that earlier. I mean, it's just, we want to give the best standard of care for our patients, but at what cost?
Yes.
At the cost
there's
of
only
time.
There's a finite amount of minutes in an hour.
Well,
yes.
And another practical question is the CDT recognizing this, coding this for you, or is it just part of your scaling and root planning appointment? Do they have their own special codes that you could submit for?
That's a really great question and something that I hope to see in the future. There's not a specified code for, bacterial reduction or even decontamination. So what I see most offices or facilities doing is billing out kind of a D4999 as an unspecified periodontal code. And the majority is kind of looking at what CDT codes are about. They're about the procedure. They're not necessarily about the equipment that you use. So sometimes that kind of throws a little bit of a challenge because they don't necessarily want to kind of define something as, okay, we're going to have a laser code. We're going to have maybe a code on bacterial reduction. I think could be valuable, but we're not there yet. So,
But it would not necessarily be considered a covered procedure, though, right? So
no, but just how would you code it?
It kind of doesn't really matter at that point, right? You can have an internal code if you
could.
wanted to.
That's true.
You're exactly
literally
right.
LBR, and then your explosion code could come up, and then
you're exactly right. You're exactly right because it isn't going to insurance. So,
which is kind of the whole issue. Like I know as hygienists, we're supposed to be trying to submit to insurance, as much as possible, saying, "Hey, insurance company, cover this for the future." But until we have, like you said, a really specific code for each of these procedures, it's not.
And it's a hard balance between, choosing a code based on the equipment or the products that we're using versus the code for the actual procedure itself.
Right. And independent of insurance, just having that CDT code, which is supposed to be a non-biased coding system.
Exactly. Yeah. Exactly.
I mean, could you, theoretically, other than the $49.99, but could you theoretically have a bacterial decontamination code, and then if you happen to use Diode, use Diode. If you happen to use some sort of other irrigant, use an irrigant.
Exactly.
Is that what you would do?
That's what I'd like to see in the future. That's kind of my hope in kind of the laser world, is to really look at okay, we are treating a bacterial infection, and how can we code this to be accurately representing what we're doing? So I think there's been progress made in coding, but I think we have just that little bit more to go to, maybe learn a little bit from medical and the ICD-10 codes and learn from how they're coding, because, man, they code way more than we do.
Yeah.
So what can we do to learn from them and maybe not go that deep, but how can we code things to be a little bit more accurate to what we're actually doing?
Well, I think the thing is, we've talked about this on the podcast, probably a lot, but, having that treatment code, right,
Mm-hmm.
code, but then also have a diagnostic code. Mm-hmm. And when you have a diagnostic code and then the only outcome with, like, an insurance company would look at that diagnostic code and then they would look at that treatment code and make sure that they're matching, making sure that there's, 3 or 4 different CDT codes at that point, but your diagnostic code is going to be the same.
Absolutely.
So you could do,
Right.
to your point, you could do we could specify that it was diode. We could specify that it was any other, modality for decontamination based off of this one thing.
Yes.
But the problem that I see as hygienists, what we do generally is we say they need a quote unquote cleaning, right? We just need to get in there and do this stuff.
Yeah.
We don't care what we call it. We don't care how it's described.
But
let me
get
tell
a
you about their
little
tissue.
side tunnel track,
Their gingival margins. We'll just.
But how fortunate someone that gets to have SRP with you because of that tradition, that extra treatment that isn't expected but a wonderful surprise. And very beneficial.
Yeah, and, truthfully, the outcomes that I've seen have been, remarkable, and it's really great to see patients, return to health in that way.
Do you find that students are pretty accepting of new things like lasers, or like does this feel like just normal to them? Because for us, like lasers is like, oh my gosh, it's the next frontier, right?
It's really interesting just being in education with the students. There truly is nothing that faces them because they grew up on
Except for board exams.
Right. Well, okay, that's very true. Except for the crippling anxiety that board exams give you. But I mean, they grew up around technology and, switching softwares or integrating different intraoral cameras or, they're hungry for it. They want it. They're used to it.
Right.
They're seeking this out in their personal life. It only is logical that they're seeking it out professionally.
So incredible. These kids, man.
I know. They absolutely floor me every time.
Can we switch gears a little bit?
Yes.
And go into local anesthesia?
Oh, my favorite.
Not to like put
how
too
do
much
I
into
have a
one
favorite?
episode. I know. But again, you're so darn passionate about it that maybe give us a top couple of things about local anesthesia that just makes you so happy.
Oh, absolutely. I was telling you actually that I was talking to a few hygienists before giving my presentation on local anesthesia, and a lot of the response was, I'm still, a little bit insecure about it. I'm not super confident in my local anesthesia. Maybe it's something, okay, if you don't use it, you lose it kind of a mentality. And one thing that I did that really, again, propelled me, putting me in situations to push me outside of my comfort zone is I volunteered for an event, Mission to Mercy event that gave free dental care, and I forced myself to register for the anesthesia booth. And I did a local anesthesia for 10 hours a day, 2 days in a row.
Yes.
And I totally immersed myself in that. And I 100% was insecure and not confident in my injections. And at the end of those 2 days, I felt like I could conquer the world. And so when you put yourself and you dive head first into these situations, whether you say, you know what, doc, okay, I want to do all your injections for the next whatever that looks like for you, but jiving in and really immersing yourself, it really can help kind of get those lack of confidence or insecurities out a little bit more. But that's one thing that I found to be particularly helpful with local anesthesias. Just
Erika,
get back on that bike.
Did you have that same experience? Were you just dropped into a bucket of just giving shots everywhere? I definitely was with our clinic.
Yeah, well, so when I first started right out of school, very confident actually, feeling really good about it, using it often, then moving to a state where hygienists weren't allowed to do it for a really, really long time, had just become able to. And so nobody was. The doctors weren't expecting it. Hygienists were using Orikicks and anything possible to avoid it for SRP. They'd all taken a weekend course and were really intimidated. So I didn't really have I used it a little bit on my own. And then moving back to a state where it was allowed and long-term, because Washington State is, leader in local anesthesia for hygienists, really doing a lot for my own patients, because I saw a lot of perio patients, and then as well as administering it for the doctor every day, pretty much here and there, and welcoming it, and the assistants would come by and need someone to do it, and I'd like to do it, and that really forced me. And as we were talking about earlier, you can go by the textbook, but until you see a bazillion patients and their anatomy, and you adapt to their anatomy, that confidence, it actually becomes fun, and then you take care of them, and they feel that comfortable injection. And you're able to talk them through it, and just
You're the first one
magical.
that got them profoundly numb too.
Yes.
They had that flared mandible, and it's not.
Exactly. That anatomical variation is something that can be so intimidating for people, but I mean, to me, I try to look at it as an opportunity to learn, because I'm like, this is a great challenge for me to tackle. Like, let me learn about your anatomy. What makes you you? Like, I am ready to dive in there and, I mean, use your tactile sensitivity, use your hands, use your fingers, feel and palpate. Oftentimes I'll see clinicians kind of just retract with a mirror or their finger, and they're just going in blind for an IA without actually palpating. And I'm like, man, this is your opportunity to see, okay, how are you unique? What do I have to navigate? How do I need to adapt for you? And that's kind of all about hygiene in anyways. We're always adapting our care for that individual.
Yes.
You're an absolute nerd. I love it.
I really am.
But to both your points, though, the thing is that anatomical variation is a real thing, and until you see hundreds of patients in that same exact situation where the posture of their tongue is sitting in a certain way, but then the degrees of how wide open that they can open and what that does for each of your landmarks completely changes everything.
Comfortable just moving my patient around too.
Yes.
They don't have
good point.
You go in, the doctor's got him on their head, and it's like, okay, well, he has him here, so this is where I have to work. No, move the patient and move them for, say you're doing half mouth anesthesia, move them for the upper or the lower where you're comfortable and you're going to be effective.
Or even move your own body.
Yes.
I think oftentimes we get stuck in our dominant chair position where we're like, well, I'm right-handed, so I can never move out of my right-handed clock position. I mean, who's to say, why can't you go over to the left side? If you can get better, visibility, and you can assess your landmarks better, do it.
Yeah.
Absolutely.
Yeah, I think for me, I'm a stander, right? And
Me too. Me too.
Are you?
I stand for the IA.
Always for the IA. What is? I mean, I always stand no matter what, but what is with that? That's when I started doing
Visibility control.
that's what it is.
Having them up just a
it's
tiny
like the
bit.
power stance. You
Yeah.
stand up, you're ready to just
Ready to rock and roll.
it. Power stance.
when you wake up first in the morning, you have to take on the day.
How happy is
Hold
your
on.
patient?
What is this? Explain this procedure. That this is a very
The cape goes flying too.
Yeah, I was gonna
Yes,
say your postures. Okay.
Even if mentally you don't feel like you're ready to take on the day, you have to stand there with your hands on your hips, and you're like, I am ready to take on the day. It's the same thing for the IA. You just stand there with your hands on your hips, and you're ready to go.
I'm gonna put that on my mirror.
The patient's
I can take on the day. Repeat after me. I can take on the day.
But how happy is your patient if you're confident you're in the correct position and you can give them the most comfortable, effective injection possible?
Absolutely.
Great.
They're so appreciative.
Yeah.
What are the biggest obstacles that you see that the everyday, not the students, but the everyday clinicians making for local anesthesia?
I would say that, and I wouldn't necessarily call it a mistake, but sometimes it's a very easy thing to overlook is before the needle actually goes into any tissue, the biggest thing that we can do is look at our pre-anesthetic assessment. What anesthetic am I using? Why? Why am I choosing this anesthetic instead of just, grabbing a lidocaine 2% with 1 to 100,000 epi, our standard, kind of gold standard? Okay, well, if you were to sit there and ask, why did you choose this? It's blank, And so, this is
that's what doctor uses.
It's
so
in the
fine.
drawer.
It's the first thing I grabbed.
So
It works.
Exactly. So talking about metabolism. Okay, we know that patients have a variety of medical concerns, more now than we've ever seen. And so choosing an anesthetic that's primarily metabolized in the liver versus having an opportunity to have a more simple liver metabolism, having first gone through blood plasma metabolism or lung metabolism, like
Articaine. Big Pharma and Articaine. I love this.
And Prilocaine. Don't leave out Prilocaine.
No one uses Prilocaine. Come on.
I think you needed to come to my course today.
Oh, I definitely need to. But do people really use it that much in private practice, though?
It's my go-to for plain. Absolutely.
Really?
Absolutely. More than mepivacine.
Let's get into this. Yeah, we should have been in your course. I'm so sorry. I wasn't podcasting called, but more than 3% mepivacine.
Absolutely.
Tell me more.
Okay, so
sorry to preface this.
Yeah.
If you on almost any Facebook message, and it's not just hygienists, mostly doctors that say it, they always do the 1-2 combo.
Yes.
3%, 2%,
yes.
3%, 4%.
Yes.
That's what they do. I'm sorry, Articaine and Lidocaine or mepivacine. So
it is.
Tell me
very
more.
popular. So what Prilocaine really kind of wins out, in my opinion, one is its metabolism. So it's metabolized first in the lungs, and so it's a more simplistic liver metabolism. So patients that have hepatic issues, patients that are on beta blockers, that reduces hepatic blood flow. How many people do we know are on beta blockers, right?
Yeah.
So it gives you a more simplistic liver metabolism. The other side of that is it's very comparable to lidocaine in that it has the same half-life of 96 minutes. It has the same pregnancy category, pregnancy category B. And so it's really comfortable for people to kind of switch their focus and say, okay, I'm really comfortable with lidocaine. Prilocaine is formulated as the plain version, in a way as what you're seeking out in lidocaine. Mm-hmm. The other thing is Prilocaine, I call it the wild card, because in a plain formulation, it can do that pulpal anesthesia for 30 to 40 minutes if you're injecting as an infiltration or a supraperiosteal. But it's a wild card because it can actually get up to 60 minutes of pulpal anesthesia in a nerve block. And so it can kind of play both sides of being short acting and intermediate acting as an anesthetic, while also being the least vasodilating and the least toxic. So for me, comparatively to mepivacine has one of the longest half-lives. It is 113 minutes as its half-life. And so it's, significantly higher. Mm-hmm. And to me, I mean, when I'm making that decision for a plain anesthetic, and Prilocaine's obviously formulated with epinephrine as another alternative option. But when looking at plain, Prilocaine is really my go-to, especially in hygiene procedures. I need a little bit more than that short-acting duration. So doing those nerve block injections, you can get a little bit longer.
You said an hour?
Mm-hmm.
About? Yeah.
Yep, approximately. Mm-hmm. Yeah. And that's pulpal anesthesia, so soft tissue is a little bit more.
Sure.
But
you have me convinced.
And I'm not sponsored by any anesthetic,
no,
so I want to make that very clear.
No, that was good.
I'm not endorsed by Big Pharma or anything like that.
I'm constantly amazed by all of the words coming out of you right now.
Well, thank you.
I am so happy for you, and I think your students are so lucky, and I think that people in your circle are so lucky to have you. If you had one kind of last thought, and it could be, I would specifically like it addressed to the students and the new grads. I don't feel like they get as much attention as maybe the people that have been practicing for a while.
Well, they have a special place in my heart, so I can always talk to them. But
what do you think?
I think my last thing that I want to say, it goes for sure, my students, my new grads, but I think this goes for anyone, is if you feel stagnant in your career or you're questioning, why did I do this? Why did I get in here? I'm just clocking in, clocking out. I'm not getting fulfillment in my career. Seek out more information. I am obviously a nerd, and so I enjoy this, but go to classes, seek out information, challenge yourself, go out of your comfort zone and see what's out there, because I am telling you, greatness is on the other side of your comfort zone. It really, truly is. And so if it's scary, do it. Do it safely, of course. But, seek out information, talk to people, interact, network, learn, always be a lifelong learner, because that's really what's going to ignite your fire and keep you going.
Alyssa, if someone wants to reach out to you, what's the best way to contact
Well,
you?
you can find me on Instagram. It's Mrs. Alyssa RDH. So MRSALYSSARDH. Or you can email me at alyssa.delgado@mnsu.edu. That's the best way.
Awesome. Thank you so
Thank
much for being on. This has been
you.
fantastic.
I know, it's so fun. Thanks.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.